Welcome to Achieve CE. We hope that you find this experience to be both convenient and educational. Thank you for joining today's webinar. If you're interested in more live CEs, Achieve CE releases a new one every week. Aside from our live webinars, we also offer Homestudy webcasts, Homestudy monographs, and special mini credit courses called CE on the Go. Access all our existing and upcoming pharmacy CEs when you become a member. Get unlimited pharmacy CE access for one low annual price. Today's webinar is titled The Pharmacologic Art of Managing Anxiety in Primary Care, presented by Jineane Venci, PharmD, MSCI, BCACP. This activity is 1 hour long and is accredited by the Accreditation Council for Pharmacy Education and approved by the Florida Board of Pharmacy. This activity is also currently streaming live on Facebook. There will be a live question and answer session with Dr. Venci by the end of her presentation. If you have any questions at any point of the presentation, feel free to ask them in the Q&A chat box below. By the end of the webinar, a 4-digit access code will be displayed on the screen. You will need this 4-digit access code to confirm your attendance and continue to your evaluation in order to earn credit. Your credits will be automatically submitted to CPE Monitor and/or CE Broker. If you have any concerns, you may contact us via live chat or email us at info@achievece.com. Dr. Jineane Venci received her doctorate of pharmacy from the University of Buffalo School of Pharmacy and Pharmaceutical Sciences, and a Master of Science in Clinical Investigation from the University of Rochester. She completed a PGY1 residency and is board certified in ambulatory pharmacotherapy. Dr. Venci has no actual or potential conflicts of interest to disclose. This activity was also developed by Achieve CE, free of any commercial support. Please join me in welcoming Dr. Venci.
Thank you for joining this discussion on the art of managing anxiety in primary care. At the conclusion of this talk, you should be able to recall first and second line therapies for management of anxiety, develop an approach to adjusting pharmacotherapies for anxiety, and implement management strategies for navigating QTC prolongation concerns. So let's get started with a case. AB is a 75-year-old female who presents for follow-up on anxiety and depression, which have worsened since the sudden loss of her husband 2 months ago. Since his passing, she reports a 20-pound weight loss, difficulty eating and sleeping and chest tightness. She denies suicidal thoughts or ideations. Prior to her husband's death, she was on bupropion XL, but does not feel that this is helping. She paged the on-call provider last month for anxiety and was prescribed 0.25 milligrams of clonazepam twice daily. She reports that this has helped reduce her anxiety and allowed some improvement in eating and sleeping. She would like a new medication for her anxiety. In the past, she has used fluoxetine with some success and citalopram, which she did not feel was beneficial. Her past medical history is significant for generalized anxiety disorder, depression related to grief, hypertension, diabetes, and hyperlipidemia. She lives alone in the house that she had previously shared with her spouse. She does have family in the area who is supportive, but she feels like she's bothering them. Recently, she met a new friend who lost her husband 6 years ago. She does not smoke or drink. Her current medications include bupropion 300 milligrams, 1 tablet in the morning, clonazepam 0.5 milligrams, 1/2 tablet twice daily, metformin XR 1,000 milligrams, 2 tablets with dinner, amlodipine 10 milligrams, 1 tablet daily, and atorvastatin 20 milligrams, 1 tablet daily. She appears anxious, but physical exam is otherwise unremarkable. So we'll come back to this patient in a bit, but first I'd like to review some general principles of treating anxiety. Serotonin reuptake inhibitors, which are the SSRIs or SNRIs, are considered first-line therapy for generalized anxiety disorder, and patients should have an adequate trial of at least 2 different serotonin reuptake inhibitors before moving on to another class. I want to stress that an adequate trial is considered 4 to 6 weeks, at least 4 to 6 weeks at a therapeutic dose. So if someone starts on sertraline 25 milligrams and they're unable to tolerate it after a week because of GI effects, this does not mean they failed the drug. It means that we need to try them at a lower dose and try and improve tolerability. So maybe restarting them at 12.5 milligrams daily, and then we wouldn't reassess efficacy until they've been at a therapeutic dose. So around 50 milligrams per day for at least 4 weeks. And then when we do increase the dose, we want to make sure that we're doing it very slowly to minimize side effects, particularly the agitation that can occur in anxious patients. This may present as worsening anxiety or insomnia that occurs shortly after a dose increase. Typically, this resolves within a couple weeks. If patients are really having a hard time with tolerability, we can move to liquid dosing and go up by like a milliliter per week if we need to. So we go as slowly as we need to make it comfortable for the patient and making sure that we're waiting until the symptoms have resolved before the next dose increase. When we stop therapies, we need to taper them to minimize the potential for discontinuation syndrome, and we'll go over some specific strategies on how to do this later on. And then lastly, we want to use the side effect profile of the agents to our advantages. So considering things like the presence of insomnia and poor appetite in patients who need adjunctive therapies. To the best of my knowledge and research, no SSRI has demonstrated superiority over another. Not all the SSRIs are FDA indicated for anxiety, though the class is pretty much used interchangeably for it. And as we just talked about, it is important to start the doses low when you're treating anxiety to improve tolerability and minimize the potential for initial worsening of symptoms. So my general recommendation is to start with half of the starting dose used for depression. If the patient is tolerating well, you can double the dose every 1 to 2 weeks until you get them into the therapeutic range. If they're having difficulty, I tend to suggest smaller increases and often recommend something like hydroxyzine or a small supply of a benzo during this initial starting period. Many times, anxious patients will end up needing doses at the higher end of the range, especially if they have OCD-like tendencies. So the process of getting them up to that dose can be slow, and it is important to remind patients of this, especially if they're coming from something that they're used to having a quick onset, like a benzo. Most SSRI side effects are dose-related. GI intolerance is one of the more common ones, and this should improve with time. Sertraline may cause a bit more diarrhea than the other agents, but otherwise the incidence is pretty comparable across the class. Drowsiness or insomnia are pretty typical as well and very much patient-dependent. So we tend to think of fluoxetine as a more stimulating SSRI and sertraline as a more sedating one, but this isn't something that's going to necessarily be true across the board for each individual patient. So these side effects, if they develop, should improve with time, but they may not always completely go away and can be a reason why a patient needs to try another agent within the class. SSRI-induced hyponatremia is something that can get overlooked and is particularly common among older adults, especially if they are on thiazides or other sodium-depleting agents. So this is something that tends to emerge with time rather than go away, and if it does develop, it may necessitate a change of therapy. Then lastly, sexual side effects are also fairly common and again tend to emerge rather than go away with time. They can be a major barrier for patients to want to continue therapy. Sometimes we can mitigate the side effects by decreasing the dose or augmenting with another agent such as buspirone or mirtazapine. So these two agents lack sexual side effects and in some cases may help offset some of the sexual side effects produced by SSRIs. If a patient prefers not to be on two different agents, you can try to switch therapies altogether, so switching to buspirone or mirtazapine. When you look at the SSRIs as a class, paroxetine may be a little less tolerable than the other agents, It has some slight anticholinergic properties that can add to the side effects. It's also pretty short acting, so patients are going to feel it quicker if they miss a dose. SNRIs are the other class of serotonergic agents considered first line for anxiety. They're pretty similar to SSRIs, except that they have additional activity on norepinephrine receptors. So a little pearl about venlafaxine, at lower doses, it behaves more like an SSRI, and it doesn't start to have norepinephrine activity until the dose gets into a moderate high range. So there are a number of SNRIs on the market. Venlafaxine and duloxetine are the only two that have FDA indications for generalized anxiety disorder. And again, we want to start these doses low and then proceed slowly into the therapeutic range. For duloxetine specifically, there is not a lot of evidence that doses above 60 milligrams have added benefit, but regimens of 90 milligrams per day and 120 milligrams per day are still used clinically, and patients do report benefit. This is something I tend to approach with a grain of salt. It can be an opportunity to minimize polypharmacy if the benefit's unclear. If the patient's stable, you can try and do a dose reduction. If their anxiety worsens, it's easy to simply return to the higher dose. Similar to SSRIs, SNRIs can also cause GI upset, hyponatremia, sexual dysfunction. This class may be a bit more stimulating and be more likely to cause insomnia, but again, this is going to be patient dependent. They can also cause dizziness, which can occur with SSRIs as well. Venlafaxine can slightly increase blood pressure or heart rate. Generally, it's not something that I worry too much about unless a patient has significantly uncontrolled hypertension. And some additional factors to consider with both classes. All antidepressants carry a black box warning for suicidal ideation among children, adolescents, and young adults. So if this occurs, it's usually within the first few months of starting treatment. And we still use these drugs in this population, we just monitor them more closely. As for older patients, which by definition is those over 25, the data suggests that antidepressants have no effect on new onset suicidality and may even have a protective effect as age increases, particularly among older adults. Discontinuation syndrome is another consideration with these drugs. Some degree of withdrawal can be expected if an SSRI or an SNRI is abruptly stopped. Typical presentation is dizziness, fatigue, malaise, nausea, restlessness, insomnia. Sometimes you'll hear people describe brain zaps with the SNRIs. When these develop, it's usually 1 to 3 days after stopping therapy or missing multiple doses, and they resolve once the medication is resumed. This does tend to be a bit worse with the SNRIs and also with paroxetine. Paroxetine has a short half-life, and withdrawal symptoms can essentially be expected if the drug is quickly stopped or even if some doses are missed. Fluoxetine is the exception. This drug has a very long half-life and essentially tapers itself. So for this reason, it can be a good option for a patient who you think may not be reliably adherent. QT prolongation is another common warning that pops up when you're prescribing or dispensing these agents. We'll get into the details of this later, but for now, just know the risk is most significant with citalopram, particularly at higher doses. In patients without other risk factors, risk with other SSRIs or SNRIs is fairly negligible. Weight gain is a bit questionable. Often patients will report it, but if you look at the literature, it is difficult to tease out whether it is the medication or improvement of the underlying condition that prompts weight gain. So reversal of unintended weight loss secondary to anxiety. Duloxetine is the exception here. It's generally been shown to be weight neutral and may even promote a slight loss. Risk of GI bleed is something else that comes up as a warning with a lot of serotonergic agents, particularly if they're also prescribed an NSAID. There is data from large observational trials that suggests a potential relationship, and there is biologic plausibility as well. So SSRIs inhibit serotonin uptake by platelets, which would then alter aggregation. However, a true risk has not been established. Clinically, this is something I personally don't worry too much about unless a patient is at an exceptionally high risk of bleeds. Getting into the second-line agents now, Mirtazapine can be a good option for anxious patients who also have insomnia or poor appetite or would otherwise benefit from gaining weight. It can be used as monotherapy or as an adjunct to an SSRI or SNRI. It does act on serotonin receptors, but as long as both the SSRI and Mirtazapine are dosed within the typical range, and there aren't a ton of other serotonergic agents on board or significant potential for drug interactions, I don't worry too much about the risk of serotonin syndrome using this as an adjunct therapy. Interestingly, this drug becomes less sedating as the doses get higher. So if you are looking for something to primarily help with sleep, you'll want to dose it at the lower end of the range, so 7.5 or 15 milligrams nightly. Another plus about Mirtazapine is it lacks a few of the major limiting side effects that you see with the SSRIs and SNRIs. It shouldn't cause much in the way of GI adverse effects, and it doesn't produce the sexual dysfunction that's so common with the other classes. But it does cause a lot of drowsiness, particularly at lower doses, which again is why it's beneficial for patients with insomnia. However, this can also lead to a degree of next-day grogginess, which is something to be considered based on the patient's line of work, what they need to be doing the next day in the morning, as well as their age, particularly when you consider their fall risk. It can also cause dry mouth, and some degree of weight gain can pretty much be expected with this drug. So if you have a patient who is overweight or obese, who has anxiety with insomnia, other sedating options such as hydroxyzine or trazodone may be better options for that patient. As with the other agents, it carries the same black box warning for suicidal ideation and needs to be tapered upon discontinuation to avoid withdrawal symptoms. Benzodiazepines are another option for second-line or adjunctive therapy. They're appropriate treatment for patients who remain symptomatic despite being on the highest tolerable dose of an SSRI or SNRI. They can also be used as an initial adjunct therapy to offset some of the anxiety that may develop when a patient is starting or titrating an SSRI or SNRI. Adding in a week or two of a benzo here can really help the dose titration process be more tolerable. They can also be used as monotherapy in patients who fail multiple agents from other classes and are helpful for patients who need anxiety management on more of an ad-needed short-term basis, so such as before a plane trip or before they're getting a procedure. There are some major factors to consider when starting a benzo. First off, they're controlled substances and therefore have a high abuse potential and may be subject to diversion. For this reason, we need to exercise an additional level of caution, particularly if the patient or a close family member or friend of the patient has a history of substance use disorder or diverting controlled substances. So I do want to stress that a history of substance use disorder is not necessarily a contraindication to therapy. The prevalence of mental health disorders among patients with substance use disorder is so high, and the management of these is critical to help the patient to remain in remission. So it becomes very much a benefit versus risk situation. With chronic use, physiologic dependence will develop. And what this means is if the drug is abruptly stopped, the patient will experience some degree of withdrawal. So this is not the same as having an addiction, which refers more to the presence of cravings and social impairment secondary to drug use. A patient can be physiologically dependent on benzodiazepines without having an addiction. Tolerance may occur with chronic therapy, but not always. For this reason, it's important to carefully evaluate if a patient is requesting dose increases, because you're going to need to discern whether this is a function of tolerance or a temporary state of heightened anxiety versus early signs of addiction or misuse. The main side effect of concern with these drugs is sedation, which can quickly become additive, particularly if the patient is using other sedating agents, including over-the-counter sleep aids or alcohol. So we worry about impaired driving, and among older adults or frail adults, we also worry about fall risk, which again creates a patient-specific risk versus benefit decision. Benzodiazepines can be difficult to stop for a number of reasons. One is a physiologic dependence, and two is the fact that if there's not another agent on board to help manage anxiety, such as an SSRI, symptoms can quickly return. So benzos can usually safely and pretty comfortably be tapered by reducing the dose every 2 to 4 weeks by like 10 to 15%. If there's suspected abuse, it's okay to go a little faster as long as the patient doesn't have some underlying risk factor for seizures. Withdrawal seizures are most common if the drug is abruptly stopped, particularly in patients who, again, have an existing seizure disorder, but also in patients who have alcohol use disorder and decide they are going to stop using alcohol and benzodiazepines abruptly at the same time. In most scenarios, long-acting agents are preferred to the shorter-acting ones. Alprazolam in particular has a very quick onset of action and a short duration of action. So it's almost like a light switch. And this can increase the potential for misuse when an anxious patient is experiencing such a quick onset and offset of their symptoms. The longer-acting agents such as clonazepam provide a more consistent level of control, and in my experience are also easier to taper. The exception is when a patient is using a benzo episodically prior to an event. So alprazolam could be a good choice for someone who just needs something to get them through a dentist appointment and doesn't want to feel groggy throughout the day. Serotonin modulators are another class that can be used as second-line or adjunctive therapy for generalized anxiety disorder. So of these, trazodone is probably the most common. At low doses, it can be used off-label for anxiety or insomnia. Most common adverse effects with this drug are related to its sedative properties, so things like next-day drowsiness or dizziness. There are a couple of newer agents in this class, vilazodone and vortioxetine. Neither have an FDA indication for generalized anxiety disorder, but you will occasionally see them used, usually as a third-line option. There's no data to suggest that they have a clear advantage over an SSRI or SNRI, and both of these drugs can be difficult to tolerate from a GI standpoint. Additionally, the cost may be prohibitive to some patients. Buspirone is another option. It acts on serotonin and dopamine, and clinically is often considered to be a weaker anxiolytic. It's most often used as an adjunct to other therapies or in patients who are intolerant to or resistant to SSRIs. There's some evidence that it may be less effective in patients who have been or are currently on a benzodiazepine as well. It does, however, have a low incidence of sexual side effects, particularly relative to other common therapies, and can potentially offset symptoms in patients with SSRI-induced sexual dysfunction. Dosing is 2 to 3 times daily, and the time to onset is similar to that of SSRIs or SNRIs. Occasionally, you'll see this agent dose PRN, and that's just not an appropriate use of this drug. It doesn't work on a PRN basis. The last agent I want to touch on is hydroxyzine. This is a first-generation antihistamine that's often used as an alternative to benzodiazepines, either as a PRN agent or for insomnia or for the initial agitation that can develop with starting an SSRI or SNRI. So this is a good option for patients who you feel may not be great candidates for benzodiazepines. Dosing is every 6 hours as needed, and the biggest adverse effect is sedation. Patients can sometimes develop a degree of tolerance to the sedative effects, which really makes this drug a better option for short-term or PRN use. So let's come back to our case. This was a 75-year-old female with uncontrolled anxiety in the setting of grief. She's currently poorly managed on bupropion XL 300 milligrams per day and clonazepam 0.5 milligrams per day. She did see some improvement following the initiation of clonazepam. In the past, she had used fluoxetine with some benefit and citalopram with no benefit. Which of the following is the most appropriate regimen for this patient? A, increase bupropion XL to 450 milligrams per day. Continue clonazepam 0.5 milligrams per day during the transition. B, discontinue bupropion XL. Increase clonazepam to 1 milligram every 8 hours for a total of 3 milligrams per day. C, discontinue bupropion XL. Start fluoxetine 10 milligrams for 1 week and then increase 20 milligrams daily, continuing clonazepam 0.5 milligrams per day during the transition. Or D, increase bupropion XL to 450 milligrams per day, start fluoxetine 10 milligrams for 1 week, then increase to 20 milligrams daily, continuing clonazepam 0.5 milligrams per day during the transition. Answer C. Unlike many antidepressants, bupropion is not particularly beneficial for primarily anxious patients because it can be quite stimulating. So for this reason, A and D are incorrect. We wouldn't want to increase bupropion if our primary complaint is anxiety. B is not necessarily incorrect, but it isn't really best practice to more than triple the dose of a benzodiazepine, particularly in a patient who's 75 years old. So now that we've reviewed the main options for treatment, let's start thinking about how to go about adjusting therapy. So when you see a patient for follow-up after they start therapy, the first thing you want to assess is what degree of benefit they're seeing. And this can be done using a variety of means. You can use questionnaires such as the GAD-7 or just simply based on patient report. You'll also want to evaluate tolerability. So have they noticed any lingering side effects? And remember, you want to make sure that you're waiting at least 6 weeks after the last dose change before you are assessing all of this. So if the patient is still experiencing symptoms, the first thing to ask is if they have improved at all. If not, you have 2 options. If they are on a low dose and there isn't an issue with tolerability, you can increase the dose and then reevaluate in another 4 to 8 weeks. If they're on what would typically be considered a therapeutic dose, or having issues with tolerability or affordability, it may be more appropriate to switch therapy. And then the second scenario, if they have noticed some improvement in symptoms, but they're either at the upper end of the dosage range or they can't tolerate dose increases, adding a second agent may be the way to go. In cases where you do need to switch therapies, there are 2 methods that can be used to switch in a way that is both efficient and comfortable for the patient. When we are switching, we are focused on balancing the risk of having a gap in therapy if we go too slow with the risk of drug interactions or serotonin excess if we're too aggressive. We also want to take into account the potential for discontinuation syndrome, which we discussed earlier, especially if you are switching from paroxetine or an SNRI. So a direct switch means we are stopping the old agent and starting the new one the following day, and this is a fairly efficient way to switch. It's most appropriate when you are switching within a class, like from one SSRI to another, and coming from a low to moderate dose. So this does create a potential for drug interactions, mostly so if you're stopping fluoxetine, which has a long half-life, and it can cause some discomfort, again, if you're switching from an agent that's prone to cause discontinuation syndrome. The other option is to cross-taper, which means slowly reducing the dose of the old agent while slowly increasing the dose of the new one, typically over a series of 1 to 2 weeks, changing the dose on a weekly basis. This, of course, creates a risk for drug interactions and serotonin excess as well. And when you're developing these, you are taking into account the half-life, the potential for drug interactions, the current severity of the patient's symptoms, and their capacity to follow the instructions of the cross-taper. And again, usually this can be accomplished in a week or 2, but for more sensitive patients or those coming from higher doses or complex regimens, you may need to extend that to closer to 4 weeks. So again, a direct switch is usually appropriate when you are going between the SSRIs, again with paroxetine being the exception. SNRI to SNRI, you have to be a little bit more careful because the pharmacologic properties of these drugs don't overlap as nicely as the SSRIs. Remember that low-dose venlafaxine acts more like an SSRI. You can try to direct switch, but if the patient has the capacity to understand a cross taper and isn't in a hurry to change therapies, a short cross taper may be better tolerated. SSRI to or from and SNRI cross tapers tend to be better tolerated, particularly if you are working with higher doses. If you're working with a low dose and you're going to or from venlafaxine, you can try to direct switch as well. That may be appropriate. And then with all other antidepressants, you will want to cross taper unless you're coming from fluoxetine. Again, because the half-life is so long, sometimes a direct switch can be appropriate. This table shows the approximate equivalent doses. So 20 milligrams of citalopram is about equivalent to 10 milligrams of escitalopram or 20 milligrams of fluoxetine. This isn't a perfect calculation, and you need to take into account patient-specific factors and the presence of any drug interactions, but in general, it's a good starting point. Oftentimes, when directly switching, we'll use slightly less than the equivalent dose for the first week if the patient's symptoms are relatively stable, and this can minimize any effects that would emerge secondary to incomplete cross tolerance. So for example, if you were going from citalopram 20 milligrams per day to escitalopram, you could have the patient stop citalopram, start escitalopram 5 milligrams the next day at the same time they would have taken citalopram, and then go up to 10 milligrams per day after 1 week. And again, we've talked about the importance of not abruptly discontinuing any of these agents because it can end up being pretty uncomfortable for patients. Depending on the drug, the dose, and how long the patient had been taking the medication, discontinuation syndrome can end up lasting a good couple of weeks after they abruptly stop a drug. Also, if anxiety is not completely resolved, symptoms may emerge on top of the withdrawal or discontinuation syndrome, which will further make patients uncomfortable. Benzodiazepines are unique in that abruptly stopping them can lead to seizures. This is of most concern in patients who have an underlying seizure history, those who are using alcohol or coming from high doses or were on therapy for an extended period of time. But in any case, benzodiazepines should always be tapered. Rebound insomnia is something else to consider and to warn patients about, particularly if they are coming from an agent that is being used for both anxiety and sleep. This can also occur with other agents such as Z drugs like zolpidem or even over-the-counter diphenhydramine if a patient is using it continuously. So most of these agents that are used in part or in whole for insomnia will alter sleep architecture, and then the body will require some time to get used to sleeping without them. So again, they'll be better tolerated if you discontinue them with a taper. So in general, tapers can be accomplished by reducing the dose by 50% every 1 to 2 weeks until the patient is at the lowest available dose. If someone is really struggling, you can add on or switch to a low dose of fluoxetine, and this can help improve the tolerance to the taper. You can also switch to a liquid formulation, which will allow the patient to accurately use small decrements without trying to do something like cut a tablet into fourths. And again, ideally for benzodiazepines, we would go a bit slower, something like 10 to 20% every 2 to 4 weeks. The last topic I'm going to cover is QT prolongation, and we're going to start with a question. Which of the following is considered a risk factor for QTC prolongation? A, hypokalemia, B, younger age, C, hypermagnesemia, or D, male gender? The correct answer is A. Low potassium can increase the potential for a variety of conduction abnormalities, including a prolonged QT interval. Low magnesium can do the same, which makes C incorrect. Older age and female gender are also known to be risk factors, which make B and D incorrect. A prolonged QT is defined as an interval greater than 450 milliseconds in men or 460 milliseconds in women. When the interval is prolonged, the patient is at an increased risk of developing Torsades-de-Pont, which is a ventricular arrhythmia that can become fatal. And there are a number of medication and non-medication factors that can increase the risk of this happening. So one major thing to consider is the baseline QTC. If it's greater than 450 before even starting the drug, you'll want to be a bit cautious, considering the presence of other risk factors and monitoring the patient a bit more closely. Also, if there is significant lengthening of the QT interval after starting a drug, so more than like 50 or 60 millisecond increase from the pretreatment value, it should raise a red flag. So if this occurs, it may be wise to hold the medication and then recheck an EKG again in a week or two. As we discussed with the question, electrolyte abnormalities can contribute to risk as well, particularly low potassium, low calcium, or low magnesium. Underlying cardiovascular conditions and bradyarrhythmia can also increase risk. If a patient is known to have long QT syndrome, you'll want to be pretty careful when starting meds. So even ones that you would generally expect to have a modest impact on QT can cause more profound changes in these patients. And then lastly, older age and female gender are considered risk factors as well. Now focusing on the drug-related risks, use of multiple drugs with QT prolonging properties can increase risk because the risk becomes additive with each agent. Use of drugs which can cause electrolyte abnormalities. The biggest and probably most common culprit is thiazide diuretics, but it's also something to think about with PPIs, other diuretics, etc. Use of drugs which can slow the heart rate, particularly beta blockers. The presence of drug interactions which can alter the metabolism of the QT prolonging agent. So citalopram 10 milligrams may behave more like citalopram 40 milligrams in the presence of a strong CYP3A4 inhibitor. Similarly, impaired renal or hepatic function can also alter clearance and thus lead to an increased presence of the QT prolonging agent. And then lastly, risk is often dose related, and pushing the dose above the typical dosing range can increase risk as well. So looking specifically at the agents we've talked about, the highest risk is undoubtedly with citalopram, particularly at higher doses. The other SSRIs do have the potential to prolong the QT interval, but again, in the absence of other significant risk factors, the risk is substantially lower than what you would expect with citalopram. With this being a known risk and efficacy across the class being equal, there is a compelling case to select an agent other than citalopram when you're starting therapy. However, if somebody is doing well on citalopram and has a normal EKG, there is no reason to change therapy as long as everything else remains stable. So there are a handful of anxiolytic agents that don't alter the QT, and these are good ones to keep in the back of your mind. So duloxetine, mirtazapine, buspirone, and benzodiazepines. So these are ones to consider in patients who have an underlying risk factor or a drug that's known to prolong QT, where you don't want to take the risk. These are good options for first-line therapy. So let's finish up with a case. RR is a 64-year-old female with hypertension, hyperlipidemia, AFib, and anxiety. 6 months ago, she was started on dofetilide. At this time, her anxiety was stable and citalopram was discontinued in preparation for dofetilide initiation. Today, she presents with worsening anxiety following the birth of a grandchild who now lives with her. She wishes to restart a medication for anxiety. Her current medications include lisinopril, metoprolol XL, rosuvastatin, dofetilide, and apixaban. Her recent QTCs are displayed below. All were measured after she was stable on dofetilide, and her renal function and electrolytes have consistently been within normal limits. So let's think about her risk factors for QT prolongation. First off, she's on dofetilide, which has a high potential to cause Torsades-de-Pont, so much so that it's started inpatient because you need such a close level of monitoring. Dofetilide is also a CYP3A4 substrate, and it's renally cleared, meaning drug interactions or changes in renal function could alter serum levels, and then increased serum levels could result in further lengthening of the QT interval. Her baseline QTc has been fairly stable in the 430s or 440s, so not high enough where we would be terribly concerned about starting an anxiolytic as long as there weren't any pharmacokinetic interactions with dofetilide. And then lastly, female gender and age are also considered risk factors. She's 64, so not young, but not terribly old. Perhaps you would be more concerned about age as a factor if she was 85 or 90. So now about her medication options. We know SSRIs are one of our first-line choices for generalized anxiety disorder. She had prior benefit with citalopram. However, we know this drug in particular carries a higher risk of QT prolongation than others in the class. Escitalopram is pretty structurally similar to citalopram, so that could be a reasonable choice, or any of the other SSRIs for that matter. None of them should alter serum levels of dofetilide, and as we discussed, the risk of QT prolongation is much lower with SSRIs other than citalopram. However, the risk is not absent, and cases of harm have been reported. So if we did go this route, it would be reasonable to have the patient come back for a repeat EKG after starting the drug and then maybe again after increasing the doses. Our other first-line option to consider are the SNRIs. As we discussed, duloxetine does not significantly impact the QT interval and shouldn't affect dofetilide metabolism or elimination. Pharmacologically, it's less similar to citalopram than some of the other choices. Again, recalling she's done well on this in the past, but in terms of QT effect, it is a lower risk option. Other alternatives include buspirone and mirtazapine. Again, neither of these should interact with dofetilide or prolong QT. So maybe trying duloxetine and seeing how she does. If she gets a partial benefit, maybe adding buspirone or mirtazapine as an adjunct therapy. And then if she's getting minimal or no benefit, trying an alternative SSRI with monitoring. So in summary, SSRIs and SNRIs are considered first-line therapy for generalized anxiety disorder. Patients should receive an adequate trial of at least 2 agents in these classes before moving to a second-line option. Initial worsening of symptoms is possible during the initiation of therapy. This can be improved by using a low starting dose, slowly increasing doses, and providing a short supply of benzodiazepines or hydroxyzine during the initiation period. When switching therapies, cross-tapering or direct switches can be used to minimize withdrawal symptoms while preventing gaps in therapy. And risk of QT prolongation is highest with citalopram, lowest with duloxetine, mirtazapine, buspirone, and benzodiazepines.
Thank you, Dr. Venci, and thank you all for participating in today's live webinar. Please enter your questions for Dr. Venci into the Q&A chat box now. She will do her best to answer as many questions as possible during the time allotted. Please also note that the evaluation code needed to access your evaluation is 8085. Once again, your evaluation access code is 8085. Dr. Venci, I will hand it back over to you for the question and answer session.